Hello, everybody, and welcome to this week's episode on Fit as a Fiddle. I am really excited to share our guest today. Today we have Dr. Neel Mehta. He is the Division Chief of the Weill Cornell Pain Management Center, and he's also the Associate Professor of Clinical Anesthesiology at Weill Cornell Medical College. Dr. Mehta and I met at a course that he was speaking at and had put together really from ground up. It was one-of-a-kind course run by Weill Cornell Medicine, and we learned so much. It was a lovely, lovely course. We had an interdisciplinary team of amazing people who are all fantastic within their fields, and Dr. Mehta brought wonderful insight into spine health and orthopedics and surgeries and how we approach treatment of people with back health and how that happens in New York City by all these wonderful doctors. So Dr. Mehta, thank you so much for being on the show with us today, and thank you for making the time to talk about your research study.
Sneha, thank you so much for having me. It's really exciting to finally be able to connect here on your podcast because part of the mission that we have at Weill Cornell and my personal goal is to kind of spread knowledge of ways that people can make themselves feel better, maybe with ways that they aren't commonly known. So your powerful podcast helps disseminate, I think, really important information.
Oh, thank you. I'm really happy to be here and with like-minded professionals as well, and doing this good work. So, Dr. Mehta, tell us a little bit more about what you kind of do on a day-to-day basis and what your role is within Weill Cornell and what brought you into the space in the first place.
Sure. So my background is I was trained as an anesthesiologist. So I've done operating room anesthesia. I've put in nerve blocks for surgery where people are having orthopedic cases. But then one thing I really liked was the almost instant gratification of helping people that are struggling with pain. I saw that firsthand when I was training and doing labor and delivery epidurals for women, and saw that they were, miserable, and once you place the epidural, that they felt a lot better. And I said, well, there's a larger population that potentially can benefit from what we have to offer, and that's where I got into pain management. So I did a fellowship in pain management at Weill Cornell, and then I stayed on as faculty, and then eventually was placed in a leadership role. Part of my day-to-day is also I'm one of the co-directors of our larger spine center called Ox Spine, which is a joint venture between Weill Cornell, New York Presbyterian, and actually Columbia Medical School. So we hope to create one of the largest spine centers in the country, certainly New York City. And my day-to-day is I see patients 4 days a week, where I see people that may have back pain for 6 weeks or 60 years, or they have other kinds of nerve pains or whatever may be ailing them, that we can try a variety of treatments, whether it be medication, physical therapy, and then even some of our interventional procedures, from simple cortisone injections into the back and neck or joints, and then muscle treatments, or even we've done some advanced therapies where we've placed medical devices like pacemakers right around the spine or nerves to try to help relieve pain. So it's pretty cool that way. And then in addition to that, we have a mission for education and research. Education, we train medical students, residents, and fellows. We have visiting folks also from all over the world. And then we try to do some research to help expand our knowledge base. So that's how we spend our day.
Wow, very, very busy guy is
Yeah.
what it sounds like,
Yeah.
doing lots of different things. That's so amazing. I'll just chime in when you said that you were an anesthesiologist in labor and delivery. I just remember the life-changing moment when I was in 43 hours of labor and I was like,
Oh
just give me
man.
the epidural.
Oh
And
boy.
then my husband was like, you went from being like this crazy person to like suddenly like joking around and like having a good time and, doing your usual like banter with the doctors and the nurses and the medical students. I was like, yeah, I don't remember any of that, but all I remember was being like, oh God.
It's life-changing. And I remember that feedback, and I thought, like, this is really powerful stuff. I mean, lots of medicine helps people, but
Yeah.
almost instantaneous gratification like that is rare.
Exactly. And I think one of the big like mantras that a lot of uh moms are chanting nowadays is you don't get a trophy for suffering, which is kind of leads into the work that we're going to talk about today that you've been up to. Of course, there's a time and place for medication, and we of course know that sometimes it can get overused or abused and used in different ways. But when used appropriately for the right person in the right dosage for the right amount of time, can be life-changing and can prevent someone from suffering. That's a good segue into just talking about LDN, which I'm sure you're going to dive deep into and explain what that is. Personally, I have had just a couple of patients who have used this medication who found it extremely beneficial. A very few handful, I could probably count on one hand. So I know that it's not widely known enough, which is another reason that we're talking about it today. So I'd love for you to just start chiming in with like the very basic, what is LDN and what is it used for first?
Sure. So LDN is an abbreviation. It stands for low dose naltrexone. The first two words are obvious. It's a lower dose. But what is naltrexone? Well, naltrexone was a drug that was discovered for a very different purpose. It was used and FDA approved for the treatment of addiction, especially those that suffer from gambling or alcohol abuse. Uh, it's a way to sort of break the cycle of reward for behaviors that we want to end. So when you take this pill, it's a 50 milligram dose, or 50, and that dose is there to help stop release of your natural endorphins that would occur with some of these behaviors. And your body tries to counteract by producing more endorphins, but it never really has a chance to release them because of this block of the medication. But it was discovered that when you use a smaller dose, maybe 1 milligram or maybe 4.5 milligrams, that block of endorphin release is very transient. And because of that, the body temporarily tries to ramp up your endogenous or your internal endorphins. And endorphins are involved in our pain relieving and pleasure pathway. So this block is occurring, but it's only occurring for a few hours. And in the meantime, your body's ramping up production of endorphins, but can't release them. And then the drug kind of disappears out of your system and the endorphins kind of release. And a lot of pain sufferers, unfortunately, may actually be depleted in some of their natural endorphins. And that's why this drug is potentially so helpful. So I discovered it sort of accidentally. I mean, I heard about it through some colleagues who were using it very anecdotally. There was very limited research about it, but we tried it, and I think our success rate was pretty low. You try one set dose and maybe a couple of patients that had kind of unfortunately had failed a lot of different treatments and didn't really see anything remarkable. But the more we tried it, we were starting to get some successes, and I realized that there was more to it than just one dose for one type of patient. And that's where I think, my work has kind of evolved. I've now have a few hundred patients on it and a variety of conditions and a variety of dosing that we can talk about.
Yeah, absolutely. Well, thank you for that introduction. I hope that listeners just got a general understanding of what endorphins are, and how they might, play into your pleasure and happiness and just feel good kind of a feeling, and how important it is when somebody is in chronic pain. And Dr. Mehta, you can chime into this a little bit more. Um, it's not just the physical tissue damage is what we've realized, right? So that's one aspect of how how and why people might experience pain in the presence of true tissue damage that can be visually seen or seen very clearly on imaging, especially post traumatic incidents or an acute injury. But then there's also the chronic pain, pain that maybe didn't happen because of any onset of something crazy, right? Like a car crash or a fall or anything like that. Or maybe it did, and then over time the tissue has healed, but then we see that patients might be experiencing pain at significantly high levels that's limiting them. And nobody's making that up, right? Is what we've also, as clinicians and as people who work with patients, we have to understand that when people experience pain, that is a real feeling for them. And that's driven by a lot of different things in neuroscience that we can talk about. And maybe you can touch on a few of those things, but we can try to figure out if we don't necessarily need to heal a tissue, which would be, certain drugs might do that, or certain kinds of therapies or surgeries or injections and other kinds of things might want to physically treat a tissue that's damaged. There's also other ways to tackle the suffering that goes behind pain. So I don't know if you wanted to comment on any of that or talk about the way you describe that in your work or to your patients.
Yeah, so I think there is a definition that's sort of accepted among those that treat pain, and that's from the International Association of the Study of Pain. That pain is a feeling that suffering or ailment that sometimes can be seen and sometimes can't. And so much of what we are working towards is trying to get an understanding by hearing the patient's perspective and description, understanding what we see potentially on physical exam and any relevant testing, whether it's imaging like MRIs or X-rays or so. Yeah, and some may be in a more of an acute injury that just doesn't heal and sort of lingers longer, or some are more genetic conditions. One of the things that we'll dive into about LDN is that it seems to work well for a lot of patients that suffer from hypermobility or Ehlers-Danlos syndrome, which has a genetic component to it. What this drug is not is it won't help you with an acute pain where you break your bone and you start taking this medicine. Probably won't make a difference. If you have surgery, this is not a drug to use for that. But with more of a chronic condition, it can really help. And this is important because so much of pain management has been stagnant for a bit, right? And we haven't had any real new medication that's been successful and FDA approved and put into use. There are lots of different drugs that go through clinical trials. It's like less than 1% chance of acceptance that drug will make it out of clinical trial and actually be able to be used.
Yeah.
So since I've been working for about 15 years, there hasn't been a new drug in over 15 years.
Wow.
So this is really, exciting stuff to be able to try for patients.
Wow. Yeah, that's a surprising finding, but I mean I believe it, but that's so surprising that in 15 years we've hadn't had anything. Okay,
Right.
so let's kind of transition into the study itself.
Sure.
So maybe you can just talk about how you guys set it up, what the methods were, and what you found, and what that means to your patients, and what it means maybe in a larger capacity too to people around the world.
So we knew that our patients were an energetic bunch, happy to reveal their positives and negatives of using LDN, and happy to spread the word about the treatment. And I thought, what a great way to get insight into how they truly are benefiting. But what I also realized is that my way of prescribing may be unique, and I'm not sure whether that's actually what's happening outside in the community with other providers, internationally. So we just set up a really basic questionnaire that we used through a lot of support groups. So there's a very powerful group called LDN Research Trust that people who use LDN or learning about it can go to. It's online on Facebook, and they have a website and a mailing list. But also then there was some other LDN support groups on Reddit and Facebook and so forth. So we polled them asking, if you are over 18 and have been using LDN for a painful condition. And that was important because LDN has a variety of things that it's being used for. And we were most interested in what it was for pain, because that's our area of interest. So they had to have been using it for 6 months. It had to have been for a painful condition. And then we just asked what their experiences were like. So what dose did they start at? What dose did they end up on? How long did it take to get to that dose? What sort of side effects did they experience? How well did it work? And what was their underlying diagnosis or condition that was presumed to be painful? And what was really interesting, first off, was that we put the survey on. Actually, initially, anytime you do a study, you have to get approval from something called the Institutional Review Board, or the IRB, and that's just to make sure that you're doing ethical and safe research. So I posed the questionnaire to them to get approval, and they said, we're not really sure if people are going to understand your questionnaire, so why don't you just pilot it? So we piloted it overnight and got 200 responses. So I
Wow.
had to shut it off, and then we revamped a couple of questions after feedback from some of the respondents, and then did it again, and we got like 450 responses in about 4 days. So
Wow.
clearly, as I said, a very energetic and passionate group, and really excited to hear what the results are. So then we looked at the data that we saw, and out of about 300 responses where they completely filled out the questionnaire, so we had to throw out those that skipped questions or so. We saw that the vast majority had either fibromyalgia or some Ehlers-Danlos, some sort of muscle condition, or some sort of nerve condition like interstitial cystitis, shingles related pain. Fibromyalgia is also considered like a nerve disorder. So we saw that there was a variety of conditions that were responding, that they were predominantly female. It just happened to be the respondents, but it was like 90% of the users were female. The dosing was really interesting. They all kind of settled around 4.5 milligrams, and that may be because that's what they were told to take. That was the limited literature that other prescribers were using as a reference. So they were on that dose, but it doesn't necessarily mean that that was the best dose for them. And that over 75 to 80% of them responded that either it was really amazing, like excellent response, or very good response in terms of pain relief. So,
Amazing.
in pain, a lot of our therapies, when we look at just placebo has an opportunity for about 30% benefit. If we take a drug that's successful in being better than placebo, you're lucky if you get even a 50% reduction in pain, or even if 50% of the people respond to it.
Okay.
Here, to see a high rate of users that were getting in the 90s in terms of how much improvement they were making, I mean, that was really, really quite remarkable. Now, there are some limitations. One is that this is a select group of people, in that they're more likely to interact with the support group because it's working. Those where it didn't work, they eventually move on and leave the support groups. And then number two, they're more likely to respond about their positive benefit to others. So, we have to take it with understanding that limitation, but we saw that the drug was very well tolerated, that the side effects were minimal, like some vivid dreams or maybe some minor headaches that resolved, and that it wasn't very challenging for them to take the medication daily. Another question was more about the practical approach, like who prescribed it, who suggested it for you, and we found that it was a variety of people, like pain management, rheumatologists, but even some natural doctors or chiropractors there that made the suggestion initially. They researched it online and found their primary care doctor to prescribe it for them. And that it was also very, very cheap. It's not covered by insurance, but it's on average costing them $30 to $45 a month as an out-of-pocket expense compared to many copays being that high.
Mhm.
So very accessible for patients, in terms of treatment. So I thought that, it's useful to share that. We are writing up our analysis. We're going to publish it into a journal. But what we thought was at least we could disseminate some of the information and hopefully it resonates with patients.
Yeah. Well, firstly, I'm shocked and amazed that you guys got like 200, 400 responses when you threw that out there.
Yeah.
I do think we live in a world now where like reviews and like writing things about products or services is a little bit more kind of just accepted. If you look on Amazon reviews, you'll see, I read them, but I've never written one of those reviews personally, but I know that how passionate
Hmm.
people can write when things are really negative or really positive. So that's great
Hmm.
that you guys got a good response, firstly. And now I'm going to ask you a really stupid question, Dr. Mehta, if that's okay.
There's no stupid questions. No,
Okay.
no, please ask.
So somebody's listening to this and they go, well, why should I take this over like acetaminophen or ibuprofen for my pain? What's your response
Yeah.
there?
So I'll say that this is, again, I mentioned earlier that this is not a drug that's meant to be for someone recovering from an injury or recovering from surgery. This is those that have more long-standing chronic pain. And chances are they've already tried those basic first-line therapies. LDN is number one, important to share that this is off-label. Off-label means that the FDA has not officially studied or approved LDN for the use of pain. But so much of what we do in pain management is considered off-label. There are drugs that we use for conditions that may be related to ones that were approved, but they're not directly studied, and that's the reality. I mean, some of the nerve pain drugs that we use are actually repurposed antidepressant drugs or anti-seizure drugs. So that's important to share. But also, number two, chances are you've tried those first line therapies and either they didn't work or they have side effects that created problems, or maybe there's interactions with your medical conditions or other drugs that you take that you are concerned about, like you've had a history of reflux or heartburn, or maybe you're on a blood thinner and therefore you can't take Advil or ibuprofen. Maybe you have liver conditions that prevent you from taking acetaminophen. So this drug may have an opportunity there, but also that it works very differently. We mentioned the endorphin pathway. That's sort of a theoretical explanation. There has been some basic science research that postulates that some of its effect is anti-inflammatory, but different than the
Hmm.
typical steroid or ibuprofen based. So yeah, I think that it provides another mechanism to treating pain beyond acetaminophen and ibuprofen.
Yeah, I love that. Um, and then one of the things that you had just mentioned, just in terms of side effects, and has there been any other studies or anything else that's been out there, maybe even internationally, regarding the side effects and also on different doses? Because I know you said this is very specifically for the low dose side of this drug. So has there been anything else out there that we know more about the side effects of the drug?
I think it's mostly similar type survey work or reporting of case reports. So it's important for listeners to understand, how does a body of evidence come about? So when you're in practice, if you try something, you tend to say, okay, well, I've had one patient that really responded. Let me try it again. And maybe you create a series of patients, a case series, we call it. So you report the positives and the negatives out of that. As you start to grow the number of patients that you have, you can start to track some of the outcomes, positive and negative, out of that. Maybe there are registries that are out there as well that may share information across other practices. Um, that's where we are in terms of our evidence. There are some limited randomized control trials. So randomized controls, now you say, okay, we're going to take the population, we're going to divide them in half, and half we're going to get X and the other half we're going to get Y. And often it's against a placebo. So there are some studies like that where they've looked at maybe 30 patients or 50 patients or so, but never anything in the hundreds or thousands of patients. So the side effects that we know are just generally what's reported anecdotally. So and through our survey, we saw people responded that vivid dreams, not necessarily nightmares, but vivid dreams was most common. Maybe a chance of insomnia. There is reporting that they get increase in energy. Maybe that also is what causes insomnia. And dosing has evolved. We used to give this at night, and then we saw the sleep disturbance. Now we give it in the morning, and actually people take advantage of the increase in energy.
Interesting.
Um, yeah, so then other things are more common, like any medication. They could have indigestion, they could have headaches, they could have nausea. Um, and if that doesn't go away, then ultimately we stop the medication, which is very easy to do. But sometimes it's just dose specific and they just go down a little bit on it. And I think that's another point to make here, in that I've talked a few times about what is the right dose. And because the literature talks about certain doses that were tried, like 4.5 milligrams, people have sort of started at that and patients don't necessarily respond. So is that a failure that the therapy didn't work, or is it that we just didn't pick the right dose? So over time, I have started to start really low. I start people at 0.1
Mm.
and I titrate to 1 milligram over the first month. And then in the second month, I go from 1 to 3 milligrams, 0.5 increments at a time. And then the third month, I go from 3 to 6 milligrams. And that is what has helped capture more patients, because we realized that maybe there was a lower dose that worked. And also that it's not necessarily that more is better. Some have actually, on their titration upwards, gotten to a dose where they really were happy. And then as they climbed, they started to feel worse again. So that part happens. And then the third thing is that you need time to build it up. So you can't like rush through the titration in 2 weeks and expect to find the right dose for you.
Yeah.
So that's just experience that has helped us with that part.
Yeah, and I'm hoping that you are sharing that information too to other people, because that's
Yes.
a really important thing. I don't know a lot of clinicians who would be just so methodological about like, what are we giving, when are we giving it, and then keeping track of that. A lot of times, here's the medication, bye, right? So it's
Right.
really important to do what you guys are doing and keep following up. The follow-up is also difficult, I know, because there's so many patients and they're on so many different things. And are they even making it to their appointments? Are you guys setting up telehealth to keep track of this stuff? So I can imagine how challenging it is, but it just makes the work that much more formidable and make it worthwhile to pass on to other people internationally, I'm sure, and share these findings and make sure that you guys are doing the best for your patients.
Right. It's been something that I've had to bring in my team to help me. So when it was just me, every patient would see me, they would see me in follow-up. And then when we started to realize that it was getting overwhelming, we scaled it. And now we're creating a little more instruction that's self-help there, so that, we created a blister pack with a pharmacy where it's very easy to understand the titration pack. Um, and they report into our portals so that they don't necessarily have to wait for a visit. They just tell us, hey, this is working well, or, I'm having this challenge. It's the only way we can scale it. It's not making us any money. We're just trying to help more and more people with it. We think that it's a real great way to bring new patients to our center.
And I love that. And I guess that just goes to show you and your team that you work with, how dedicated you guys are to patient care and patient outcomes. It's not always the case, and to see like a institution and people within it who are just really just doing this because it's the right thing to do and really feeling like they're seeing results is incredible. So that transitions into kind of my like last question about all of this, with LDN and the work that you guys are doing. What is the future? What are you guys planning on doing down the line? Is there a way of collaborating with other institutions, not just in New York City, but maybe elsewhere? What are your guys' plans, even if it's not something that's well thought out, or well put out there?
Sure.
What are you guys thinking?
Well, the ultimate dream would be to figure out a larger scale study through the NIH. That takes a dedication and a skill set. NIH money is important, but also very hard to get, and you need a really dedicated research team with experience to qualify for that kind of a grant. So that's something that we're working on. In the meantime, we just gather our registry data and try to spread the word about it, and hopefully feed into this registry with how people are doing. Um, and then in general, just thinking about other ways to help people with pain. I think, collaboration, as you've seen with our muscle pain and soft tissue related conference. I mean, that was just a pilot. That was just a something that we put together with the thought that let's see what happens. We expected maybe 15 people to attend, and we had closer to 80. And we saw a lot of networking going on, and realizing that we're just one aspect of treating pain. And so many modalities are being done by amazing people that we don't know about. And how do we bring the conversation to bring that all together? That's another mission that we have, less to do with research, but more to do with collaboration and patient care. And then the final mission is really, how do we collaborate in a way that's open and in dialogue? So one of the things I noticed that with patients, they say, okay, you've made a referral, but I go to that person and they don't really know much about me from you. That communication from provider to provider, doctor to physical therapist, therapist to acupuncturist, whatever it may be, creating that network of open conversation is another mission. It's easier to do in your own department, but now as we start to expand the web, I think that's where patients really realize that there's miscommunications along the way, and maybe the wrong treatments or missed opportunities. So that mission, as simple as it may sound, is actually probably the hardest.
Yeah, absolutely. And it just takes a lot of effort, right? Communication, getting to know people, making sure you're on the same page, even if you're not treating in the same way, which is that's not expected. We expect different professions and people with different backgrounds to treat differently, and that's the point of an
Right.
interdisciplinary team. But at least to have that cross communication, so that it
Right.
works cohesively. I love that. Dr. Mehta, do you have anything else to share on this topic or the work that you guys are doing that you feel like you've missed out so far?
No, I thank you for the opportunity, and I hope that this is a dialogue that continues. And if your listeners are interested in learning more about LDN, we've certainly written up some stuff on the web about it. And then if you're interested in potentially seeing if it's right for you, certainly come pay us a visit in our practice at Weill Cornell.
Absolutely. And I'll put the information for how people can reach out to you guys in our show notes. So listeners, you can go right there and read about the work and get in touch with Dr. Mehta and his team if you guys are interested in paying them a visit. So Dr. Mehta, thank you so much for being here, for chatting with us, and for your valuable time. Thank you.
Sneha, thank you. What a wonderful opportunity to be part of the show.